Okay, this is the first half of Chapter 3 talking about preparing nurses for practice and the implications of not providing residency opportunities for new nurses. Chapter 3 talks about evidence for and against using transition to practice models. It talks about the times that the new graduate nurse experiences the most stress. It compares the U.S. transition to practice against other countries and discusses the implications both legally and on the performance of the hospital for not providing a transition to practice program. We've seen physician residents, pharmacy residents, chaplain residencies. These are all funded by Medicare. 30 states have teacher programs that acclimate new teachers to the classrooms, and 17 of those programs are funded by the state. But we know that in nursing it depends on the hospital you're at, what kind of program you'll develop, how long it'll last, and how effective the program actually is. We've got to consider, as we implement our change project, the effect of the nursing shortage and the younger workforce on the units that we're trying to implement change. We know that due to retirements we're losing a lot of experienced nurses, and that in turn leads to new nurses coming into areas that we wouldn't normally see them, like ICU, ED, high acuity areas for a new graduate. In fact, myself included, some of us started out in those areas. We've got to remember as leaders that it's not only hospitals that have this problem. You also see new graduates in clinics. You see new graduate nurse practitioners in primary care by themselves. And you see nurses in home care, outpatient areas, same-day surgery, any of those kind of settings. We've got to consider the implications. Studies mentioned in the book that found 50% of malpractice came from the ambulatory settings, so we're looking at clinics and outpatient surgery, things like that. Of those malpractice suits, 2/3 caused major injury or death. And the Draycup-Morris study that is referenced in the book talked about a 50% nursing turnover by 2020. Some of those are retirements, and unfortunately some of those are new nurses that were disillusioned in their first year of practice and decided this is not for me. Other countries have some interesting ideas. Portugal has their 9-month provisional license, and then they discuss with the nurse and the supervising nurse whether that person's ready to continue on into practice and get a full license. Scotland has an exciting model that is referenced in this slide, and it provides an online mentorship. This is good particularly for places where they lack experienced preceptors, or they just don't have the volume, or places where preceptors are just burnt out. Australia uses a national licensure, and I won't dwell on the implications of that, but imagine if the United States had a national nurse licensure and a national board of nursing. And then Canada provides focus on preceptorships, mentorships. They have actually been to the Transition of Practice Committee of the National Council of State Boards of Nursing in the United States to give their input into how effective a 36-week internship is in Canada. Ireland uses also a 36-week internship. It's a paid internship and it's considered part of their education, but they actually work as a nurse intern during their final phase of school. To bring back our nursing theorists, Townsend in 1930 talked about the need to integrate theory, but at that point they just had physicians instructing theory, and Townsend realized that this was completely different from what the nurse needed. In the 70s, Marlene Kramer and Patricia Benner came on the scene. Kramer realized that in studying transitions, new nurses thought they were ready to practice out of school, and then they got into their practice settings and realized that that was not the case. Benner studied stages, and she described the novice stage as the first year. Competent stage was years 2 through 3, and then after that the nurse started developing expertise. So that goes to show us that, at least according to Benner's theory, it takes at least 2 years for a nurse to start functioning at a higher level. The Commission on Collegiate Nursing Education has developed an accreditation program for residency programs, but again, that's up to the facility whether they want to get accredited. The Joint Commission, the IOM, and the AACN, among others, have supported the idea of a national transition program. They would like to see a shift from funding diploma programs to funding residency programs. They would like at least a 1-year program, and they would like to see that funded by Medicare and Medicaid. Evidence-based practice was defined by Sackett as integrating research evidence with clinical expertise and patient values. So it's important to pay attention to the fact that evidence-based research has to have clinician and patient involvement. Without those two, you just have a researcher studying and giving ideas, and that's not going to work. The 3 levels of research are described, with level 1 being the randomized control trial, a true research study. Level 2, and this is where I tend to spend a lot of my research time, is in qualitative studies, descriptive studies, surveys. A little bit easier research to do, doesn't require all the statistics. Level 3 is just expert opinion and consensus statements put out by ANA, AACN, etc. It's important to realize that the authors of this book didn't find any level 1 evidence on transition to practice, so it's not been deeply researched. These are some of the risks related to new nurses. The low job control, because they are still functioning as tell me what to do. Job stressors, they don't know yet how to handle the constant needs of the patient. Lenient disciplinary procedures talks about how state board disciplinary actions tended to be more toward expert, experienced nurses than toward new nurses. This makes you wonder, does that mean the expectations are lower for a new nurse, and is that right or wrong? Should we expect less from nurses who have the same amount of liability, who hold patients' lives in their hands? Lack of consistent preceptors is an either-or type discussion, because some people report getting a lot more out of different preceptors, but on the other hand, a single preceptor can identify the nurse's weaknesses, concerns, and develop that relationship. So that's kind of a tightrope walk. The research found that the highest stress level for novice nurses was between the 3rd and the 6th month. And if you think about it, in most facilities, this is that time period after they're off orientation and on their own, but most likely don't really know what they're doing. The thing you have to worry about with new nurses is that if the culture isn't right, they'll look to each other for guidance. So instead of looking to an experienced preceptor, they ask other new nurses, and so this creates a situation where the wrong information can get passed around as expert opinion. A study in Norway found that nurses self-reported that they were more efficient and better nurses after their first year, but the study also found that they made the same number of errors. So basically, these nurses didn't realize their own limitations because there wasn't an experienced nurse looking over their shoulder saying, whoa, you're not doing what you're supposed to be doing. Transition programs lead to fewer practice errors. Most importantly, it makes the new nurses more likely to report errors because they are not afraid. They're not afraid of punishment. They have somebody to walk them through the process. And then we go back to communication. It gives them better skills to communicate, better skills to develop interpersonal relationships. You have to remember that for the first time they're also going to be delegating. They're going to be put in charge. They're going to be calling physicians, and all of those situations require an understanding of how to talk to the person, how to interact, how to get what you need. So these are a few of the things that a new nurse needs to be taught. Self-awareness goes back to that situation of how good do you think you are versus how good are you actually. They've got to understand the team dynamics, understand who's in charge, understand what a nursing assistant can do for them, and they've got to learn about coordinating care. They are also placed in the role of managing the entire continuum of care for the patient, and then likewise they have to manage conflict if the physical therapist comes to work with the patient who's not ready, or if the physician comes and the patient's in a test. They've got to understand how to intervene there. These are some high-level things that new nurses need to know. You at least need to start exposing them to systems thinking, to the finances of the unit, and the effects of change on the staff and on the interaction on the physicians. Think about turnover when you're implementing your project, because high turnover can give you a temperature of the culture of the unit, and it can also indicate staff that aren't ready for change. Look closely at turnover. The book talks about a 35 to 60% turnover range in hospitals, but it also says that a 7 to 10% turnover is expected. So anything higher than 10%, and the nurses are probably leaving because they're dissatisfied. Text also mentions long-term care and their early work in transition programs. Just don't forget that these other settings are out there. In the next part of Chapter 3, we'll talk about the National Council of State Boards of Nursing, their transition to practice model.